This is the podcast for a basic ECG interpretation part 2. In this podcast, we're going to discuss the normal rhythms, normal sinus rhythm, sinus bradycardia, and sinus tachycardia. So I guess maybe I should say that we're going to discuss the sinus rhythms, normal, fast, and slow. All right, so I want you to think about something for the rest of the time when we talk about dysrhythmia. So for every other single podcast that you listen to, I want you to keep something in mind, all right? The rhythms, okay, the biggest issue with the rhythms, with the dysrhythmias, is the fact that it affects cardiac output, okay? So whether it's too slow or too fast, or the pump mechanism isn't right because of something going on with either the atria or the ventricle, it's going to affect cardiac output, okay? And you know what effects the body has based on a decreased cardiac output, all right? And that's something that we'll just make mention of again in class. But I want you to go back to your congestive heart failure and think about, what happens to the patient when you have decreased or diminished cardiac output, all right? So if the heart is beating too slowly, it's not going to have enough cardiac output. And if it's beating too quickly, it's not going to have enough cardiac output. So even when we have cardiac arrhythmias, especially our atrial arrhythmias, it's the cardiac heart rate that is the factor, okay? If the heart rate is normal or near normal, then you should have a near normal cardiac output, okay? So then their vital signs should be pretty normal and their perfusion should be pretty normal, all right? You may know someone who lives with atrial fibrillation or atrial flutter, all right? It's perfectly fine, provided that their ventricular rate is under control. And that's when we use things like beta blockers and calcium channel blockers and sometimes digoxin in order to control the ventricular heart rate, okay? Because the ventricular heart rate has to do with cardiac output, all right? So I want you to keep that in mind when we talk about all these different types of dysrhythmias, all right? So we're going to start off with our gold standard, normal sinus rhythm, okay? This is the only normal rhythm we're going to talk about here in the next couple of podcasts. So normal sinus rhythm, all right, is normal electrical conduction, all right? You have a normal P wave, which remember is atrial depolarization. You have a normal PR interval. Remember, that's the time to travel from the SA to the AV node. You have a normal QRS, okay, so it's narrow and it's pointy at both ends, okay? That's ventricular depolarization, and then a normal T wave, which is ventricular repolarization. Okay, everything's normal, 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 normal. All right, you've got a regular rhythm, so the interval between the R to R is constant, and I'm going to show you what that means on the next slide. Okay, 60 to 100 beats per minute. P wave for every QRS. Every P wave looks the same. The PR interval is consistent. Okay, that's going to be important. So every PR interval will be the same. And the QRS is 0.4 to 10 seconds, or 0.10 seconds. Okay, and consistent. And everything looks the same. All right, so what do I mean by R to R interval? Okay, it's the interval between this peak and this peak is the same as here to here, here to here, here to here, here to here, here to here. Okay, so it's regular. And we'll show you ones that are not regular, okay? But for now, normal sinus rhythm has a regular R to R interval. So you're looking at the peaks, okay? Are they the same? Now I'm going to give you some calipers that, I'm going to let you borrow some calipers if you want. But you can do this with a piece of paper too, right? You get a piece of paper and you mark little hashtags where these are, and then you move the paper. Are they the same? Okay? P wave looks the same, okay? There's one for every QRS. QRS is narrow, and then there's a T wave, okay? Now, if this was a 6-second strip up here, let's count rhythms, or let's count heart rate. 1, 2, 3, 4, 5, 6, 7, 8, all right? Then the heart rate would be 80. You don't count this one, even though you see the P wave, you don't count this one because you can't see the QRS, so that does not count, okay? How about this one? If this was a 6-second strip, 1, 2, 3, 4, 5, 6, 7. So this would be 70. All right, good. Alrighty. So what's a dysrhythmia? Okay, a dys means bad, so it means bad rhythm. Okay, so it's any disorder of the heartbeat or heart rhythm. And again, cardiac output is impaired if it's too fast or too slow. Okay? And then if cardiac output is impaired, then your perfusion is also impaired. So think about everything that your heart perfuses. And that is correct. That would be all of the body. Okay? So you could have oxygenation issues or perfusion issues to any part of your body. All right? Your brain, your lungs, your heart, right? Your kidneys, your liver, your pancreas, everything else. All right? So then you need to look for perfusion issues as a sign of decreased cardiac output, blood pressure, pulses, all those types of things, okay? So keep those in mind when you're talking about issues of perfusion. All right, so dysrhythmias are classified by where they begin, okay? So the SA node, in the atria, the AV node, junctional tissue, we're just going to make mention of junctional ones and ventricular ones. So this podcast is going to deal with your sinus or your SA node ones. The next podcast is going to deal with something called supraventricular tachycardia and your atrial dysrhythmias. And then the last podcast is going to deal with ventricular issues. Okay. So dysrhythmias, something's going on, all right, and it's causing a delay or a block of the electrical impulses from the SA node down to the rest of the heart. So somewhere along the line, something's going on. All right, here's just another basic picture of the heart. So there's your SA node. Okay, remember, SA node does atrial depolarization and whatnot, and then it goes to the AV node, which slows things down just a little bit, and then gets impulsed through the bundle of His and the Purkinje fibers down into the ventricles to cause ventricular depolarization. All right, so there's some terminology. You know, there's always terminology going on here. There's 4 things, actually. So there's tachydysrhythmias. So tachy means fast, so the heart rate is above 100. Okay. Again, as you remember with tachycardia, that is one of the heart's mechanisms to increase cardiac output temporarily. All right. But it shortens the diastolic time, or it shortens the filling time, and you don't get enough blood into the ventricle to pump out. So it does decrease cardiac output. All right. And so then by doing that, then it also decreases perfusion time to everything, including the heart muscle. It increases the workload of the heart, and it also increases oxygen demand. Brady dysrhythmias are too slow. Okay, Brady means slow. So the heart rate is less than 60. All right. And the rate is too slow to provide adequate cardiac output. Okay, so it's just not beating fast enough to get enough blood out. We can have premature complexes. So that means that, let's say the SA node is firing and firing and firing and life is good, but then you get one little atrial or ventricular cell that says, hey, it's my turn, and they fire. Okay, so premature means that it comes too early. So when a cardiac cell other than the SA node becomes irritable and it fires or releases an electrical impulse, it's called a premature complex. So it will go through the system like a normal one will. It just comes earlier than it should. Okay? It can come out of the atria, it can come out of the junctional tissue, or it can come out of the ventricular tissue. And we'll talk about at least the atrial and the ventricular ones here along the way. If they are frequent enough, they could cause decreased cardiac output, okay, especially the ventricular ones. And then the last term is paroxysmal. So paroxysmal means that it's intermittent, okay? It comes and goes. It usually starts because of a premature beat, and it usually stops without any intervention, okay? So it's just something you might hear, maybe a patient has paroxysmal atrial fibrillation, okay? So some oddball cell starts the ball rolling, okay? So you get a premature atrial beat or a premature atrial contraction. And then the patient goes into AFib, but then they come back out of it, okay? This can be actually pretty dangerous because if that happens, then clotting can form and the patient doesn't know it because they're not in it long enough to really have a problem. Or they go to the doctor because they're not feeling quite right, but the EKG looks normal at that time. Sometimes this is when the patient may wear like a Holter monitor, which is a cardiac monitor that they'll keep on 24 hours a day for a day or two, sometimes 3. To try to catch these things that are happening to give the cardiologist a picture of what's going on. All right. So, what are the symptoms that you normally see with dysrhythmias? Okay, here they are. There we go. Okay, they all have to do with decreased cardiac output and decreased perfusion. Okay, so hypotension, dizziness, syncope, there's your neurological. Shortness of breath, there's your lungs. Chest pain, there's your cardiac. Okay, they may feel like their heart is racing. Okay, palpitations. Weak and fatigued, anxiety or restlessness, again because of decreased oxygenation. They get clammy, they get pale and cool. Okay? Their capillary refill is diminished because they have decreased cardiac output. Okay? Urine is affected because of decreased cardiac perfusion to the kidneys. Okay, so you should be aware of these commonly seen signs and symptoms of dysrhythmias. Okay, either Brady dysrhythmias or tachydysrhythmias. There's my little algorithm again. So again, if you want to think about this from a perspective of, is it too fast or too slow, regular or irregular, then gives you an idea about what it may be. Okay. Alrighty, so let's kick this into gear with our good friend sinus bradycardia. Sinus bradycardia has all the characteristics of normal sinus rhythm, except the heart rate is less than 60 beats per minute. Okay, that's the only difference between sinus brady and sinus rhythm. There are different causes. So vagal stimulation, okay, having a bowel movement, vomiting, that kind of thing. So the stimulation of your vagus nerve can cause bradycardia, and you should know that already. Beta blockers, okay, too much beta blocker can cause you to have too slow of a heart rate. Too many calcium channel blockers, too much digoxin can also do the same thing. Anything else that can slow down your respiratory rate can also slow down your heart rate, so anti-anxiety medications, narcotics, those types of things. But also conditioned athletes, so people that have are really fit can have sinus bradycardia and be perfectly normal. Okay, sometimes their resting heart rate can be in the 30s and 40s, but their blood pressure is fine. Okay, because their heart is in such good condition that it doesn't need to beat really fast. Okay. So just because they have sinus bradycardia does not necessarily mean that something's wrong. Okay. So how do we treat it? Well, we treat them only if the patient is symptomatic, and we treat with atropine. So then think about this for a second. What would you expect to see the heart rate do after giving atropine? You should expect to see it go up, okay, and increase, because that's the idea. All right, so here's a nice rhythm strip for sinus bradycardia. So as you can see, there's a P wave, a QRS, and a T wave. It's really slow, because if this was a 6-second strip, this heart rate is only 40, okay? So again, you're going to be looking at your patient and going, are they symptomatic? Do they have any of those symptoms of dysrhythmias? All right, and then the last one then for this podcast is sinus tachycardia. Okay, again, sinus tachycardia has all of the characteristics of normal sinus rhythm, except the heart rate's greater than 100. Okay, and so there's lots of causes for sinus tachycardia: anxiety, afraid, stress, exercise, pain, fever, alcohol, hypovolemia, hypoxemia, caffeine, atropine, nicotine, thyroid, dopamine, blah, 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 and on and on. Now, how do we treat sinus tachycardia? All right, we treat them if the patient is symptomatic, and we treat the cause. Treat the cause of tachycardia, all right? Of sinus tachycardia, that is. So, treat the cause of sinus tachycardia. Got that? Here's a nice little strip of sinus tachycardia. Now, I want you to take a look at this. Okay, here's the P wave. You see where the mouse is? The arrow is right here's the P wave. Now, this is going so fast that the P wave is getting bumped into the T wave of the beat prior to it. Okay, this is completely normal. So we can do things on the monitor to kind of stretch this out a little bit to see if indeed it is sinus tachycardia or if it's something else going on, some other kind of dysrhythmia. But in this case, everything is normal. The R to R interval is regular. You've got a P wave in front of every QRS. You've got a narrow QRS and a T wave. Okay, so it meets all the criteria of normal sinus rhythm, except that it's too fast. So let's count. So this is a 6-second strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay, so this patient's heart rate is 140. So 14 times 10. And this ends the second podcast for sinus arrhythmias, so basic ECG interpretation part 2.